We would like to invite Dr. Tejas for his presentation about the power calculation in abnormal situations, very long eyes, short eyes, post-vitrectomy.
Good afternoon. Good afternoon, one and all. Am I audible? I'm just making sure you guys don't go to sleep, because if you want to sleep, the auditorium is a better place. It is cool, dark, and quite mood lights are there. Well, so let's, after listening to the types of formulae that we have available, Dr. Alshul talking about the optical biometers that we should be using, and then Dr. Shell talking about the abnormal eyes. I'm going to talk about long and short eyes as well as the vitrectomized eyes. I might be skipping the busy slides because time is pressing. So when do we classify it as a long eye? More than 24.5 millimeters. These are some basic slides. And what are the errors that we can get? The measurement error and the formula error. What actually is the problem with a very high myopia? Well, the axial length measurement has following problems, like a fixation issue, especially with a posterior staphyloma. And there are so many anatomical variations that a straight beam of line with a non-optical is also going to be a huge problem. And so to overcome these issues, we have the optical biometry. Like Harshul explained to you, it measures right at the RP level. What could be the measurement errors? Well, vitreous liquefaction in eyes with axial myopia. What does it actually lead to? Well, we have refractive index of vitreous, which is segmental and it is different, right? Because of the liquefaction in the pockets. And hence the Gulstad standard refractive index is no more accurate. We are understanding more and more about this vitreous also. It leads to overestimation of the axial length, and you can understand that overestimation of axial length leads to a lower power, and because of that we will have a hyperopic surface, which is the first thing we should never have. Well, none of the cataract surgeries should end up with a hyperopia. I believe everybody agrees to that. Came the Van Gogh formulas for adjusting the axial length in eyes which were more than 25.2 millimeters. I'm going to explain more in the next few slides. And these are the formulas which started incorporating them with a different pair of A constants also. Then there was a Van Gogh adjustment also. Why was it? To compensate the overestimation of the axial length. They adjust, or in short, reduces the axial length by formula specific coefficient. Holiday works better up to axial length which are more than 26.5, and the SRKT works better with the axial length of more than 27 millimeters. And when I say SRKT, it is the SRKT with the Van Gogh adjustment, not the SRKT which was there in our old our biometers. It is quite an aggressive method, gives surprises of myopic error, and hence came one more change in the entire thinking, and the ULIP modified and re-optimized formulae in the website came into place. What did the ULIP do? Let's see that. Yes, very important is all these formulas do not use in refractive surgery eyes. So the Van Gogh adjustment, the new one with the ULIP also came out with certain parameters, and they found out that the Holiday optimized was better for 26.5 and SRKT was better for 27 millimeters and above. I mentioned about the liquefied vitreous. Well, so this is one instrument which is going to be helpful when your liquefied vitreous has different refractive indices, correct? And this is Argos allows you to measure in spite of different, because it sums up all the refractive indices of the vitreous cavity. So special formulas for SOS biometry, the Barrett true axial length or the BTOL is especially for the segmental biometries, the Pearl DGS and the EVO formula. I'm not sure how many of these are going to be commercially viable for us. I'm going to skip this because this is for the long eyes, that the Olsen, the Barrett and the Haggis were the top three options. Not going to. So trying to conclude long eyes formulas which to use. Well, Barrett, Kane, Hill RBF and Olsen, which are quite easily available. They work very well in all lengths of long eyes. If you want to use the third generation formula, you can go for ULIP Van Gogh modified Holiday 1 for 26.5 and ULIP Van Gogh modified SRKT for more than 27. Newer modifications of Holiday NLR for high myopia also gives better performance. Well, but this is like choosing which phone when you go to a store or which sari that you want to actually buy. In summary, optical biometer, it overperforms the immersion biometry. The newer SOS biometry is an emerging concept, and Kane, Barrett, Hill RBF versions, Hill version 3 works very well, and for third generation formula, use only ULIP modified Wang-Koch adjustment. So let's talk about the short eyes. Classification of short eyes, less than 22 millimeters of axial length. What are the problems? The axial position of IOL now becomes very important. The effective lens position. High power IOL, small shift in position leaves a big impact. I will describe that in the next few slides. 1 millimeter shift of effective lens position affects to about 2.75 diopters of spectacle powers for an IOL, which is about 34 diopters. And it changes when it becomes 40 and 45. The shape factor and IOL design are also very important. So this is no longer the purview of our IOL power calculation. It's the IOL design and the IOL power makes the difference in our IOL power calculation. High degree of spherical aberration in higher power spherical IOLs. Well, you can understand a thick bulging IOL is definitely going to leave behind a lot of spherical aberrations. So in spite of a 6/9 or a 6/12 vision, the patient is not happy optically. A small example of the axial length and how it impacts. Well, error in an axial length measurement which have higher impact in the short eyes. Like I said, in an average eye, 1 millimeter of axial corneal compression will give about 2.5 diopters, but the same thing will be about 4 diopters in a short eye. So which formulae for short eye? Well, Hofer Q. How many would use Hofer Q for a short eye? Everybody. Me also. Well, now listen to this, read this statement. Now it is an outdated concept. It was when third generation versions formulas were in use. And Dr. Warren Hill also says that for some reason it got stuck in everybody's head that you are supposed to use the Hofer Q, Holiday. One may be better, and few newer methods like Barrett and Hill RBF do even much better. So, which formulae for short eyes? Well, studies were conducted in 2016 by Kane and Mellers. And again, a very busy slide. They also came to the same conclusion that Hofer Q is one of the poorest formula for short eyes, which we have been using every day for 20 years. Correct? Barrett and Holiday 1 performed better in 21 and 22 millimeters of range. And this is a comparison between the Lenstar and the IOL Master and which formula to use with each of the machine. With Lenstar, it was Olsen and Barrett, and Olsen's CLCR is also again a different formula. It's too much to digest in 8 minutes. I will also skip this. And what is coming up for short eyes? Lens thickness. Well, it can improve the IOL position prediction when axial length and anterior chamber depth are also known. Newer swept source OCTs with lens tomography, modeling of crystal lens is also possible. And superimposing lens pre and post operative data will help in understanding of these problems. What should we do for short eyes now? Well, ray tracing works better, and oculics and phaco optics are the formula which should be used. Barrett and Holiday should be avoided in short eyes. Haigis, Olsen and Hill RBF version 3.0 results are comparable. And newer Hofer QST, newer formula works equally good for small eyes. And what are the challenges of an extreme hyperopia? Well, if you end up with an IOL power of 40-45, well, you might actually not get the IOL company of the IOL company giving you that much power. You might have to have a piggyback IOL, and the piggyback IOL also has its own problems. So in summary, for short eyes, standard cases, Barrett Universal 2, Hill RBF version 3.0, Olsen and Holiday 1 or SRKT are the standard formula that we can use. For high myopes, Holiday 1 with Wang-Koch modification, Barrett Universal 2, Kane, Olsen and Hill RBF version 3 works well. For very long eyes, which is more than 27, the Barrett Universal 2 and the Hill RBF version 3 along with Kane. And for short eyes, again, ray tracing with LT, Olsen and Oculix, Hill RBF version 3.0, Hofer Q and Haigis, the optimized one, and the Barrett Universal 2. I am sure not everybody can afford to get all this in their clinic, but you can always go and send your such patients, which would be rare, to a clinic which has all the possibilities, to a neutral surgical center which has machines and this formula which are incorporated. So coming to my last topic is the post-vitrectomized eyes. There can be two situations. Eyes without silicone oil. A patient would have undergone a vitrectomy but no longer has silicone inside the eye, and this can be considered normal, and so you can go ahead with whatever you're doing. But the challenge is that eyes which have a silicone oil inside their eye, and here you have two important considerations. One is the axial length measurement. Please remember the refractive index of the vitreous has changed because of the silicone oil, and the IOL power and the model selection. So the eyes with no advanced or mature cataract optical biometry preferred over ultrasound. Well, in fact, this is an universal statement, but sometimes eye with gas, it blocks ultrasound, and so here also optical biometry, though this is very rare because the gas usually is not a big problem. It goes away in 15 days. In silicone oil filled eyes, the sound travels slowly. 1515 milliseconds is a normal phakic eyes versus 1000, and various densities of silicone oil. So this is again another challenge. Your surgeon would have put 1000 CST or a 980 or a 5000 CST oil, and we do not actually have a data of different silicone oil densities giving us different for axial length measurements. So the low velocity with the silicone oil causes an erroneous measurement of vitreous cavity depth. The formula to correct axial length in any silicone oil vitreous is always incorporated in E-scan. I believe everybody knows that whenever you are trying to do a sonography of this type of patient, you select the mode which says silicone oil filled eyes. This is something very important. And the conversion factor of 0.71 multiplied by the measured axial length has been reported to correct for the apparent increase in axial length induced by silicone oil of viscosity of 1000 CST. There might be a small change if the viscosity is 5000 CST. Some other small tips are, well, if the eye is whether fully or incompletely filled with silicone oil, you can understand, it's common sense that if it's a incompletely filled eye and if you are doing the axial length measurement in sitting position, the silicone oil might not be actually in the path of your optical biometer, right? But it is always better to do it in sitting position. Some eyes impossible to measure. I will try and skip this slide. So silicone filled eyes, IOL power calculation, the high refractive index of silicone oil makes it behave like an intraocular meniscus minus lens. Therefore, without appropriate power adjustment, significant hyperopic overcorrection could be expected. Biconvex lenses have higher correction than plano-convex, though there are very few biconvex lenses available, and eyes with posterior meniscus also experience the smallest. So the rule of thumb is use a convex plano IOL at 3 to the calculated R power. The challenge is the patient would have a silicone oil in the eye and it is going to be removed after 2 or 3 months. Well, so how do you adjust that? So you can add 3 or 4 diopters to that. If using a biconvex lens, add 5 diopters, and when silicone oil is removed, performed 3 to 5 diopters induced myopia should be expected. So the choice is silicone oil addition to, another problem is silicone oil addition to IOL surface is maximum with the silicone oil, IOLs. However, it can also occur with hydrophobic, acrylic, PMM and hydrophilic lenses, but in decreasing order and decreasing frequency. Avoid silicone IOL, plate haptics, all this is another topic. That's all. Thank you very much.
Very nice talk, Dr. Tejas sir.